Welcome to Next Round with the Pacific Research Institute. I'm your host, Rowena Ichon. Tim Anaya, PRI Senior Director of Communications, and I had a conversation with PRI President and CEO Sally Pipes. Sally provides her perspective on the healthcare challenges that have risen from the coronavirus pandemic. She compares the U.S.'s handling of COVID-19 to those countries with greater government control of their healthcare systems, the move to Buy America when it comes to drug suppliers, the role of the private sector during this pandemic, and the growth and support of single payer. Thanks for joining us. Welcome to Next Round, Sally.
Thank you. Delighted to be able to participate. A lot going on in the healthcare space, 24/7, I would say.
I know. So let's jump right in and talk about some of the healthcare challenges that have come up in the U.S. during this recent coronavirus crisis. First off, there's a continued push for a single payer. As PRI Single Payer Poll Watch has shown, support for a single payer jumped to 9% in 1 month as this crisis has worsened. How do you explain this shift in attitude over such a short period of time?
Well, definitely Medicare for all or single payer, which, as we know, means that there is no private health care allowed under a true single payer system, which is what Bernie Sanders, Elizabeth Warren, etc., all support. I think with under Medicare for all, it has risen in the polls. At the end of March, the support for Medicare for all went up to 55%, which was up from 54% in June of 19. But a lot of the people on the left, such as Senator Sanders and Alexandria Ocasio-Cortez, feel that Medicare for all is the only way to go, and particularly with the pandemic. Senator Sanders says, "When I talk about healthcare being a human right, the coronavirus crisis makes that abundantly clear as to why it should be." And AOC, Alexandria Ocasio-Cortez, said of the COVID-19 outbreak, it absolutely is an argument for Medicare for all. And I would say exactly the opposite is true. And we can talk later about Canada, Italy, and the UK. These are countries that have very high incidences of cases of coronavirus, very high death rates, and tremendous shortages in facilities to take in new patients.
Sally, let's dive into that. You've written that countries, like you just mentioned, Canada, the UK, that have a single-payer system routinely face what we might charitably now call small health crises during annual flu outbreaks. And we've seen these same countries, as you mentioned, are now struggling mightily to combat the coronavirus. Share some of these examples with our listeners. How would switching to a single-payer system make it so much harder for the U.S. to fight health pandemics that may strike our country?
Well, I mean, the big issue right now with the coronavirus in countries like Italy, the United Kingdom, and Canada is that under single-payer systems, government decides how much is going to be spent on healthcare. They set global budgets. And what happens is, by setting a global budget, the demand for healthcare is often a lot greater than the supply, and therefore you get long wait, ration care, lack of access to the latest treatments and technology. So those are the outcomes that have happened in the UK, Italy, and Canada. If you look back to the SARS pandemic back in 2003, 2004, Canada had very, very few beds available for patients that were coming in with SARS or suspected SARS. Canada had 375 SARS cases, most of them in the province of Ontario, where the bulk of the population is, 375 cases, and there were 44 deaths from SARS. Several people ended up being in the emergency room at hospitals in Ontario for over 16 hours. And the 16 hours that they spent waiting for a bed in a ward caused an expansion of the SARS virus to the other patients in the emergency room. On the other hand, the United States had 27 SARS cases and not one single death. So I think we have to look at how a country that has a true single-payer system like Canada deals with this. And as I mentioned, we are seeing so many reports coming out of Canada from doctors and health officials saying they just don't have the capacity and the facilities to treat people with the coronavirus. In the United Kingdom, as you know, Prime Minister Boris Johnson was diagnosed with coronavirus. It got to the point where he had to be taken to St. Thomas Hospital in London, which is an NHS hospital, but it is the top teaching NHS hospital. And rest assured, he probably got the very best care by the very best of doctors. A lot of docs in the UK who are NHS doctors, the top ones also work as private doctors. Anyway, fortunately, Prime Minister Johnson did survive. But for the majority of people in the UK, the 90% of people in the UK who are covered by the National Health Service, there are tremendous waits. The pandemic numbers are on the rise. And when they surveyed, the Doctors Association surveyed 1,600 doctors recently. Only 8 of those doctors surveyed said that the National Health Service was well prepared for COVID-19. There were 4.6 million Brits waiting for hospital care in 2019, and it was the highest waiting time ever. And those numbers were actually in September, before the coronavirus situation even began in the UK. So I think, you have to look at what it means when government is the only supplier of healthcare. Long waiting lists, ration care, and as we are seeing in the UK, Canada, and in Italy, of course, which really had a tremendous number of deaths during the coronavirus. Their numbers have gone down, but they peaked a few weeks ago, but very high rate of death. And a lot of that has to do with the fact they have a very aged population. 27% of Italians are over age 65. They live, in many cases, they live in apartment buildings with elevators where, you're in a dense situation. And the fact that if you have 3 generations in one apartment, young people come in, they may have the coronavirus, but they have no symptoms, but they can pass it on to their parents or their grandparents. And the last thing is that in Italy, they have a very high rate of smoking. And so, it really took off in Italy, and we're finally seeing some sort of opening up of the Italian economy, but it's going to be very slow.
Sally, in the case of a democracy, politics continues, and it's actually even amplified during this coronavirus crisis. Joe Biden is now the presumptive Democratic presidential nominee now that Bernie Sanders has dropped out of the race. You've said that his support for a public option, which is considered by pundits to be a moderate alternative, is actually a stepping stone to single payer. How so?
Candidate Joe Biden will be the Democratic nominee. He, of course, supports a stepping stone approach to single payer, i.e. a public option, a government insurance plan to compete against private insurers, which ultimately will crowd private insurers out of the market. He's also now in his plan talking about reducing the Medicare eligibility age from 65 down to 60.
Sally, there's been a significant discussion about prescription drugs and the continued production and availability of medications during the coronavirus. This has become a complicated issue with prescription medications manufactured around the world, including in China. The Trump administration is considering using a Buy American order to bring back more prescription drug manufacturing to the U.S., while similar legislation has been proposed in Congress. You've just published an issue brief on the issue for PRI Center for Medical Economics and Innovation. Share your key findings with our listeners. Why would issuing such an order significantly complicate the availability of medication and the development of a coronavirus vaccine?
PRI just published my new brief and explaining why expanding Buy America rule would hurt U.S. patients and the economy and actually hinder the development of the coronavirus vaccine, antiviral, all of the latest testing that is needed as we encounter and get beyond the coronavirus pandemic. So if we went to a new Buy America rule, which the Trump administration is talking about producing an executive order on that, or some members of Congress, including Senator Marco Rubio, are going to have introduced legislation on this Buy America idea. I think that this would be a disaster for our supply chain. If you look at the drug manufacturing, the Food and Drug Administration in 2011 showed that it is 40% cheaper to manufacture active pharmaceutical ingredients, what we call APIs, overseas. There are 1,300 plants in the U.S. who are manufacturing pharmaceuticals, yet most of those ingredients come from overseas. We introduced a Buy America rule. We would cut off U.S. manufacturers from these international suppliers. And with just 28% of key ingredients for FDA-regulated drugs made in the U.S., a Buy America rule could lead to immediate shortages and price hikes. So we have a growing recession coming. The new mandate would hurt this economy even further than it is being hurt by the coronavirus pandemic. And innovation, America is the country in the world that is the center of innovation in pharmaceuticals and biologics. It takes about $2.6 billion from an idea of a drug or biologic to become approved through the trials through the Food and Drug Administration. And this takes between 12 to 15 years. years from start to the drug actually being available. And only about 10% of drugs that start out actually make it to the market. So it's very, very expensive. The United States does not have price controls, and so that's why the innovation is done in our country. But as to this whole issue of Buy America, we need to have better enforcement of the U.S. trade deals that we have with many countries around the world. We need to expand our skilled workforce to make our medical supply chain even more secure. These things cannot be done overnight. And so I think that we need to, as I say, better enforcement of our trade deals. We need to prevent other countries from violating the current trade deals and infringing on our own intellectual property. We must embrace advanced manufacturing technology so that we can provide more efficient production and ensure more workers are trained in science, technology, engineering, and mathematics. We have a very small supply of people with this kind of training. And so it's no wonder that a lot of this work is done not just in China, but Germany, in Israel, in many countries, Mexico. They are all countries that are involved in the supply chain of drugs. It's not just a Chinese issue. And so we need to keep the market open. We need to have more people trained to do this sort of thing. But we do need to destroy the notion that a Buy America rule would be best for our economy.
Sally, Democrats in Congress are also pushing for prescription drug price controls as their solution, claiming that the only way seniors will be able to afford coronavirus treatments or the vaccine that will someday be on the marketplace will be to cap prices. You've written that these proposals would actually do just the opposite and actually lead to higher prices and reduced availability and less innovation. How so?
It's been a major issue. And in fact, the United States is the one country that doesn't have price controls on its pharmaceuticals. And as I mentioned earlier, that is why most of the R&D, the innovation is done in this country and not in England where GlaxoSmithKline is headquartered, or in France where Santa Fe is headquartered, or Roche. Any of these companies, they all do their R&D in the United States because, as I mentioned, most drugs don't make it through to the market. And price controls would just mean that the U.S. market for innovation would also dry up. Speaker Pelosi, Democratic Speaker Nancy Pelosi, she is the author of H.R. 3, and she wants to cap 250 mainstream drugs in this country to the average price of drugs in 6 other countries around the world. This is absolutely going to destroy the ability to get new drugs to market if her bill came to pass. And on the Senate side, there are also some senators that want to support the idea that President Trump has been touting called the International Price Index, where particularly cancer-type drugs, top very expensive drugs, the price of those drugs would be tied to an average of the price of those drugs in 16 countries around the world: Canada, the UK, France, Germany. What the people in the White House have and the Senate have not pointed out to the American people that many of these drugs, which are available to Americans for treating cancer or stroke or heart, all of these issues, they're not even available in these countries because the countries, their own, say in Canada, the Therapeutic Practices Medical Review Board won't even accept a drug if they consider it's too expensive. So not only would drugs not be developed, but people would have access to fewer drugs. And as I say, in Canada and the UK, a lot of these highly priced, very effective new drugs and treatments aren't even available because the government organizations, the government departments decide that even at the price controlled price, they're still too expensive. So we have to really explain to people why price controls would destroy our pharmaceutical sector. And if one of these bills of H.R. 3, Pelosi's bill came in, it has been forecast by the White House Council of Economic Advisors that would result in the development in this country of 100 fewer drugs over a decade. So we want to continue to be the world leader with treatments not just for deadly viruses like the coronavirus, but for chronic conditions that affect millions of Americans. And these are far more responsible, sustainable ways that we have to make drugs more affordable. We can make some changes to the Medicare Part D, with the donut hole. One of the big issues for higher drug prices not being passed on to consumers, of course, is because insurance companies hire PBMs, or what we call pharmacy benefit managers, to negotiate with manufacturers over whether to include drugs on the insurer's list of covered drugs. And so these three of the largest PBMs control more than 3/4 of the market, and they negotiate the discounts or the rebates in exchange for placement on a formulary. And the drug makers have little choice but to accept. But the problem is the PBMs keep most of the savings, and they're not passed on to the consumer. We would like to see these discounts and rebates be passed on to patients so that they can more easily afford the drugs that they need for whatever condition they have.
Sally, we hear a lot of what government agencies are doing to battle the coronavirus, but you recently published an op-ed with PRI's Dr. Henry Miller talking about the important role that private sector companies are doing to help to prevent people from getting the coronavirus and developing new treatments and even a vaccine. Share with our listeners some examples of what the private sector is doing in the fight against the coronavirus.
Yes, and for those of us living in America, as you know, I'm a former Canadian. I'm so glad I live in America, and particularly during something like this pandemic, because all of the R&D is being done in the United States. The private sector has just jumped to the fore and really is doing great things. For example, a biotech company in Boston, Massachusetts called Moderna, within 42 days, they identified the final compound within the virus, and they launched clinical trials almost immediately. So they are working very hard on a vaccine. Inovio is another company that is doing a lot of work in this area. Sanofi, Johnson & Johnson, Pfizer is now working very hard to come up with a vaccine. So, we're seeing tremendous activity. And Dr. Henry Miller, our senior fellow, says it'll at least be 12 to 18 months, but we can hope that the FDA will remove a number of barriers so that the vaccine can be approved as quickly as possible. But at the same time, we're seeing other things. The biotech company Gilead, based in Northern California, their drug remdesivir, which was developed for SARS and MERS, they're now working to see if that is going to be effective in treating the coronavirus. There are two anti-malaria drugs, chloroquine and hydroxychloroquine, that treat malaria, which are also being tried in order as a means of getting people that have coronavirus to help them get better. And then, of course, we're seeing, the whole issue of people being able to have tests at home. There's a company in Texas called Everlywell. They are producing home test kits. Scanwell Health, an LA firm, has also promised a direct-to-consumer test kit. Unfortunately, the FDA has made it very clear that none of these at-home coronavirus tests have been approved by them. But I think it's time that they figured out how to do that. Then we have companies like the high-tech companies, Google. They've launched a website with authoritative information about the virus. Amazon is providing at-home testing to residents in Seattle, where their company headquarters are. Bill Gates, of course, is putting a lot of money, he and his wife Melinda, to provide funding for the development of a vaccine. The automakers have even changed their manufacturing from producing autos and trucks to producing the ventilators that are so necessary for people who have severe coronavirus symptoms and conditions. General Motors is producing 30,000 ventilators right now. So there's a lot going on, but it's all in the private sector. As you probably remember, it was the CDC that said that they didn't have, they wouldn't approve some of the tests. Some of their testing was flawed and unstable. And so, it's the government that always seems to be having these problems, but the private sector is so keen to, find a solution to this and find it quickly. And it's not happening in countries with government virtually controlled or totally controlled like Canada. These developments are taking place in America.
Sally, we always try to find a positive aspect in something horrific like the coronavirus crisis, and in this case, it's been the development of telehealth as an online at-home alternative so that people, especially in rural areas, can still receive good medical care without having to leave their homes. Talk about how telehealth has made a difference in providing health care in underserved areas during the coronavirus crisis.
Yes, telehealth is more than an emergency measure, I think, during this coronavirus. It took a pandemic in order to get some exciting changes to our healthcare system. And one has to hope that that these changes, these deregulation efforts, will go on after the coronavirus pandemic has ended. Telehealth is one of the great issues. I've been promoting telehealth for, I hate to say how many years it has been, and it was always just people would like go ho-hum and yawn. But in fact, now with the coronavirus, telehealth is really in the limelight. There are shortages of doctors, and so in many cases, people that need to see a doctor couldn't see a doctor because of the shortage. But we've seen now with President Trump in his appropriations bill added telehealth to Medicare patients so that they can get access to a doctor. I think we're seeing, and certainly New York University, NYU Langone, they just added 1,300 providers to their telehealth network. They were seeing 60 telehealth people per day. Now they're doing 1,000 a day. The famous Cleveland Clinic in Cleveland, Ohio, has logged over 60,000 telehealth consultations, 20 times their narrow 3,400. So telehealth is a way to reduce costs because people don't have to actually go to a doctor's office and the cost of all that's involved in that. But also for older people who may not have their own car or transportation, this means that they don't have to leave their home. They can talk to their doctor over their iPhone or over their regular telephone. We also are seeing that if you live in a rural community, you probably have a primary care doctor, but you may not have access to the top specialists in the field for cancer or cardiac surgery. But with telehealth, your primary care doctor in a rural area can get in touch with a top oncologist, say at Sloan Kettering Cancer Facility in New York, and things can be worked out. And therefore, patients are going to be able to get access to the very best of doctors, and their primary care doctors negotiating with these specialists will be able to get the best treatments for these people, really opening up the system so that people, can get timely care.
Sally, you've written that federal and state governments have rolled back several regulations on hospitals and healthcare providers to help them better serve patients and provide Americans with good healthcare alternatives during this crisis. Of course, many of these rollbacks will end once the coronavirus ends. What are some of these regulatory rollbacks that are benefiting patients today, and which ones do you think policymakers should keep in place once life goes back to normal?
We're also seeing some other deregulation efforts that I think are very, very promising. One is getting states to remove certificate of need laws, which are laws that mean that if I wanted to open a hospital in Los Angeles, and Tim, you already had an office in hospital in Los Angeles, you would have to grant me permission in order for me to be able to open my hospital. And of course, just like if you had a restaurant in LA, you might not want me to open a restaurant to give competition to you. So certificate of need laws have really, hampered the expansion of hospitals and hospital beds in this country. So we're seeing some changes there where the states are removing their certificate of need laws. We're seeing scope of practice rules that really are being light. They limit the supply of care available to patients. But now what we're seeing is that under the coronavirus, a lot of these nurse practitioners called NPs and physician assistants called PAs, they in many cases hold graduate degrees and advanced medical training. There are 290,000 nurse practitioners in the U.S., 90% specialize in primary care. They are now able to do things that previously they were prohibited from doing, like writing prescriptions, diagnosing patients, and giving vaccines and things. This will take the pressure off this, what we think is a shortage of medical doctors that, as the American Association of Medical Colleges has said, by 2032, we are going to have a shortage of 122,000 doctors. And so letting nurse practitioners and physician's assistants do a lot of things that they are actually qualified to do will allow doctors to be available to treat patients who have illnesses and conditions that they really need to treat. So scope of practice, deregulation, telehealth, getting rid of certificate need laws, and finally licensure. If I graduate as a medical doctor in California and I take the California test and I'm approved and I am now a doctor in California, but that license that I get to practice medicine in California would not allow me to go and practice medicine in Nevada or Arizona or Washington State. So we're seeing now some of the states are adopting new reducing these licensure rules so that I, as a doctor in California, could actually go and practice in New York or in Arizona or wherever there is a need for my services. So these are all things that really are very, very important. And last but not least, I think, medical school is, as you know, very hard to get into a medical school and very expensive to do your medical training. But American students spend 4 years getting an undergraduate degree, most going into medicine, their degrees are in science, and then 4 years to get a medical degree. And then if you want to become a specialist, about 4 to 6 years after that. We are now seeing some developments which, take place in other countries, which mean that the training to become a doctor, the time frame has been reduced. And so we're Harvard and New York University's Grossman School of Medicine just announced that 2020 medical graduates were able to graduate early and start practicing as doctors. And medical schools in Duke, at Ohio State, and at University of North Carolina, Chapel Hill, their medical schools are now offering students a 3-year medical degree. So this will greatly expand the number of doctors available, reduce students' debt, and really make this shortage that is being predicted, as I mentioned, by the American Association of Medical Colleges, be smaller. Because if we move to a Medicare for all single-payer system, a lot of that number of 122,000 docs would probably grow significantly. But opening up the market so it takes fewer years to become a medical doctor, I think will increase the supply, reduce the cost of training, and actually, be terrific in this country, as several other countries have shorter time frames for becoming a doctor. Getting rid of con laws, shortening the number of years to go to medical school, telemedicine, licensure, deregulation cutbacks, and scope of practice. Those are all the things that, I am really hoping that will continue after the coronavirus. And I think President Trump, is very much in favor of most of these things which would open up the market. One last point, short-term limited duration plans, people like Speaker Pelosi say, are junk insurance. They're sabotaging healthcare. These are the kinds of plans that many of the young people who've lost their jobs and their health insurance would be terrific as an interim measure or even for a longer-term measure where they can get a short-term limited duration plan for 12 months, renewable up to 3 years, not one of the 10 Obamacare essential health benefits or have to be part of those plans. And they're really, a great option for people who, have lost their coverage. But because of people like Speaker Pelosi saying they're junk insurance, they've sabotaged Obamacare, many states have decided to ban short-term limited duration plans, California being one of them. Only 19 states right now are allowing them. And we need to open that up because all of this reducing regulations, opening up the healthcare system is really going to lead to universal coverage. Universal choice in healthcare will lead to universal coverage. Government regulation and government takeover of our healthcare system will be very detrimental to Americans and their access to the best healthcare systems in the world.
Finally, Sally, our listeners who are stuck at home but enjoy a good glass of wine have been encouraged by new state policies allowing residents to buy wine from restaurants when picking up food and making it easier to deliver wine to your doorstep. So what wines are you enjoying these days while we're all sheltering in place?
Yes, it really is interesting. A restaurant in San Francisco, Spruce, which has a very elaborate and expensive wine list, opened up their wine cellar and sold off a lot of their very expensive wines to raise the funds to pay their employees who, are not able to work while the restaurant is shut down except for a small takeout. So very exciting things happening. I, as you know, am a huge fan of French rosé wines. And I think during this pandemic, while we have a supply in our own house, I think if we didn't, I would recommend that people go to their local restaurant where they're doing take-home and try to buy a bottle of rosé to try at home. But I love Whispering Angel from France. I love the French Miraval wine. I like Ott has a really great rosé wine. So they're all really fantastic and not that expensive. There's also another French rosé called Belle Rouge, which is very, very reasonable and very, very tasty. And in California, the Charles & Charles rosé, which is very inexpensive, is really a great rosé. So I encourage people to enjoy light rosé wines, which are easy to digest and are pretty reasonable.
Thanks so much, Sally. Special thanks to my boss and friend, PRI President and CEO Sally Pipe, and to my colleague Tim Anaya. If you like this episode, please tell your friends and subscribe to PRI's podcast at iTunes, Google Play, Stitcher, or TuneIn. And please do us a favor and give us 5 stars. You can also listen to our podcast on PRI's YouTube page, youtube.com/Pacific Research 1. That's the number 1. Thanks for listening. I'm Rowena Ichon. Hope you'll come back again for next round with PRI.